postpartum depression, and we'll look at recognizing depression during pregnancy and during the postpartum period. And we'll look at some treatment options. I have no financial disclosures. I will mention a few newer treatments that aren't FDA approved but are going through the process of FDA review. So what are the odds for pregnancy? In a broad sense, we tend to think of pregnancy as this event that has been planned and thought through, but in reality, 50% of pregnancy in the United States are unintended, and not surprisingly, teen pregnancies have a higher likelihood of being unintended. And pregnancy is fairly common. Over 80% of women have children by the time they reach 40. So what advice do we give patients in general before becoming pregnant? Folic acid, healthy diet, exercise, and using contraception. When families ask about depressive symptoms during pregnancy, I often refer them to the Massachusetts General Hospital app. Especially younger patients really like this app. You can download it for free from any app store, but the program lists several depression screens in kind of an easy to use format, and it gives a wealth of information. So especially the younger patients, I have them start with this even before I do the consult, if possible. Most facilities use the Edinburgh Postnatal Depression Scale. This is a 10-question scale. I sometimes administer it myself because we don't always get paperwork to the patient and back in time, so it only takes a few minutes to administer. And it looks at, does the patient have symptoms of depression, and how serious are those depressive symptoms? Postpartum depression is fairly common. About 10% of new moms will have postpartum depression. When you look at comparing postpartum depression to depression in the community, it's not that different. Roughly 10% of the population at any given time has significant symptoms of depression. If a patient has had postpartum depression previously, there is a greater likelihood of postpartum depression the next pregnancy. We use the term postpartum depression, but in general, any depression during the period of pregnancy is considered peripartum or related to the pregnancy. So 20% of these depressive symptoms actually occur prior to the pregnancy starting. Sometimes 40-50% of them will start during the pregnancy itself, and then 40-45% will occur postpartum. And there's some debate about what should we really be calling all of this. If the depressive symptoms don't start until a certain point, should we use different terminology? I sort of think of it as depression is depression, and if it's related to the pregnancy, we'll treat it a little bit differently, but we should just identify it as depression. When looking at when postpartum depression actually occurs, the first month tends to be the time when we identify it most commonly, and that may be a factor of the mom is just delivered, she develops depressive symptoms. The first thing that comes to mind is postpartum depression. As we get a few months out from delivery, we tend to use the term postpartum depression less often. When looking at new moms and depressive symptoms, we want to try to differentiate between the baby blues and postpartum depression. And the textbooks make it sound like, oh, this is clear cut. But when we see a mom 3 days after delivery or 5 days after delivery, it's really hard to tell that is she sad and feeling blue, And will this get better in a few days, or is this going to be a full depressive episode that takes therapy and medication to treat? Baby blues are fairly common. A lot of families will describe mom having some depressive symptoms for a few days, and it gets better within a week or two. Families that go through postpartum depression, we try to make sure they meet the full criteria for major depression, which is the SIGE-CAPS criteria. What kind of episodes or what kind of risk factors increase the risk of postpartum depression? Pretty much all the adverse events that we think of for our ACEs, stressful life events, being young, not having support or a partner, having numerous children increases the risk of postpartum depression. Of course, if there's physical violence, sexual abuse, emotional abuse, the risk of depression is much higher. Some other risk factors that we think of in psychiatry are patients that have personality disorders. If a mom's had premenstrual dysphoric disorder for years, the risk of postpartum depression is higher. If they have other psychiatric illnesses, especially the anxiety disorders, the risk for postpartum depression is elevated. Dads can develop depressive symptoms. Somewhere around 5% of new fathers will describe depression. And it's the same stressors that lead to postpartum depression in women leads to postpartum depression in men. The lack of social support, stresses in relationship, stresses in the environment. This slide's from a billboard ad that was probably 10, 15 years ago in Chicago and some of the Midwestern cities, looking at sparking some discussion about teen pregnancies and that males are responsible for a big, well, they're responsible for teen pregnancy, and that we should probably include looking at teenage males, especially when we're exploring issues related to pregnancy. When we think about adolescents that become pregnant, everything is tougher. They have less social support in general. They have a lower social economic status. The dads involved in teenage pregnancy are much less likely to be involved. And when school or work is interrupted when you're age 15, 16, 17, it has a very profound effect. Missing a period of work when you're 25, 30, 35 is a big deal, but it can often be planned for, and employers are much more accommodating to their adult workers than they are a teenager. And the same is true of the school and education, that if a youngster misses 6 months of school or a year of school, it becomes very difficult to return to education. Untreated psychiatric disorders carry risk for moms and babies, and when we think about our psychiatric patients, the risk of alcohol and tobacco use is very high. If you've ever rotated through an adult psychiatry unit, the rate of tobacco use is close to 100%. And obesity increases the risk for obstetric problems. In general, the risk for malformations or major ones is 3 or 4%. The rate of premature delivery is somewhere around 10, 12%. And gestational diabetes, 2 to 7%. And I bring this up as we discuss what are the risks of treating depression. So in general, not treating depression carries its own risk, that depressed patients are less likely to follow guidelines from their physician and their caregivers. There's a risk of prematurity when moms have depression throughout the pregnancy. So what are the regular recommendations from the American Psychiatric Association and the OBGYN groups? In general, mild to moderate depression should be addressed with psychotherapy, education, and checking for comorbid substance abuse problems. In moms that are trying to conceive, we recommend that they reach a plateau or a period of time where they're feeling fairly well prior to getting pregnant. In my practice, that rarely happens. That it's hard for patients with chronic depression to reach full remission, and they often make a decision with myself and other family members included to proceed with a pregnancy even though they have some depression and there is increased risk having a pregnancy while depressed. If a mom is doing really well, we will taper antidepressant medications and discontinue them prior to pregnancy. If the depression is continuing, we try to optimize the medication and we continue it throughout the pregnancy. And the recommendation is for medication in patients that have severe depression. In addition to depression, we have to worry about anxiety, and so many of the patients that have depression have a comorbid anxiety disorder. We tend not to ask them as much about anxiety as we do depression, but it really impacts level of functioning and how they respond to therapies. 10% of postpartum women will meet criteria for an anxiety problem, but as you know, it's pretty much 100% of families going through a pregnancy and a delivery have significant anxiety. It's a very anxiety-provoking time. Untreated anxiety during pregnancy increases the levels of cortisol and catecholamines, which could cause some problems for the fetus. There's some studies looking at babies born in a situation where there's high levels of anxiety. These youngsters may have a slightly higher risk of ADHD. If we didn't treat postpartum depression at all, what would happen? Well, it gets better on its own in general. Most cases of postpartum depression resolve after a few months. By the first birthday, 75% of moms are feeling much better, but 24-25% still have depressive symptoms. By the time the infant has reached 2 years of age, 10-12% of moms will still describe depressive symptoms, and that's consistent with 10-15% of the general population describes depression at any given time. One of the questions I get nearly every time I see a mom that's delivered, she will ask, what are the odds I'll have depression again with the next pregnancy? And pretty straightforward that it may be as high as 40-50%. It's a big deal, and I support moms having more children, but we have to plan for it and try to put in place all the safeguards we can to treat the depression and mitigate the kind of risk of having depression throughout the next pregnancy. Should we use antidepressant medications? And this is a big topic in psychiatry in general. How effective are these medicines, and should we be exposing fetuses to Zoloft, Paxil, Prozac, etc.? Previously, there was the letter categorization system that the FDA applied to all medications, and it would tell you, roughly if the medication is dangerous or really dangerous. But it really didn't give you the data that you needed, which was, is it worth the risk to expose mom and infant to this medication? And the pregnancy and lactation labeling rule, which is probably I'm guessing 8 or 10 years old now, has a much more nuanced discussion in the medication label so that you can read through it, and they will go over the pros and cons of using a medication during breastfeeding, pregnancy, and even include sections, if there is data available, what is the effect of the medication on males' reproductive abilities. The nice thing is you can get a real sense of how risky it is to use the medication, but it's more complicated when explaining it to family members, that there's not a clear-cut answer, should we use this medication or not? And we're pushed to have a more thoughtful discussion of here's the pros and cons, and working with families to come to a decision. In America, we use a lot of selective serotonin reuptake inhibitors. At any given time, as much as 10% of the population may be on these medicines. And that's similar to the population of pregnant moms. 8% are on SSRIs. Europe and Asia use less SSRIs, and I don't think there's evidence that one approach is better than the other. There are lots of studies about serotonin medications in pregnancy, and every 6 months or so a new one comes out, and it is popular in the press. But in general, the gist of SSRIs is that they're not particularly harmful during pregnancy. As I mentioned earlier, the risk of SSRIs needs to be weighed against the risk of maternal depression, that care for the fetus and the infant is less optimal if the mom is depressed. This slide is usually presented in every talk about SSRIs during pregnancy, and I don't know how meaningful it is. These side effects listed for antidepressants are really quite rare. The persistent pulmonary hypertension, major malformations. If there is an increase compared to not using antidepressants, it's relatively small. Most of the patients I see are on SSRIs, didn't know they were pregnant at first, go a few months through their pregnancy, and then show up in my office and ask, should I stay on the antidepressant or not? And one study took a look at what happens if you stop antidepressants during pregnancy. And roughly 40% of patients will have depression again during the pregnancy, and that breaks down to, if they stayed on medication, there was a 26% of another episode of depression, or if they stopped medicine, almost 70% of those became depressed. And I suspect that relates to, if someone is on medication, they usually have significant depression, and stopping the medication often leads to depression coming back. We see that in our population of non-pregnant individuals with depression. So if they became pregnant, they were on an antidepressant, they were probably on it for a solid reason, that they needed it, and when it stopped during pregnancy, there's a fair chance that depression will recur. What about breastfeeding and SSRIs? And oh boy, this goes back and forth all the time, and the psychiatrists tend to be on the sidelines saying, let's use medication all the time through pregnancy and through breastfeeding, and OBGYN and others appropriately saying, wait a minute, let's make sure we're using the least amount of medication and using it only if it's absolutely needed. We're in an environment now where breastfeeding is really pushed not only from medical providers, but from the community and family members, that there's a lot of pressure to breastfeed. But in general, I recommend if the medicine is working fairly well, please keep taking it. If we need to start a medicine, we pick one that's worked well previously, try to avoid polypharmacy, try to avoid the medicines that are really problematic, the lithium and the valproic acids. And if we need to use antipsychotics, we worry a lot and we look for dystonia. Substance abuse during pregnancy is just a real conundrum, and the NICU staff is quite familiar with the impact of opioids throughout pregnancy. What causes postpartum depression? Everyone has their favorite theory, and it usually involves something with estrogen, progesterone, cortisol, sometimes melatonin, sometimes oxytocin. There's lots of theories, but in general, there's probably something going on in the axis that involves cortisol. And I don't claim to understand this graphic completely. I've had a couple lectures on the GABA-A receptor, and the GABA-A receptor is located predominantly in the hypothalamus, and this receptor is in the middle of this whole chain of ACTH release and corticotropin releasing factors and the interaction with the adrenal gland. It's coming up in this talk because we're now looking at allopregnanolone, this molecule that impacts the GABA-A receptor, and that's the little yellow stars, and the GABA-A receptors there in the middle on the hypothalamus. And through all these complex interactions, the allopregnanolone impacts how the hypothalamus communicates with the pituitary and this whole cortisol release process. Now, when someone is pregnant, there's a placenta also releasing placenta corticotropin releasing factors, and that impacts cortisol. And during pregnancy, there's a lot of allopregnanolone, and the pharmaceutical companies took a look at this and said, well, this is a molecule that we can replicate and produce and administer. Let's try this for depression. And this is exciting from a psychiatrist standpoint because our toolbox was SSRI, another SSRI, an SSRI with a slight adjustment in it, and that's all we had. And they've come along now saying, hey, maybe we can use allopregnanolone as an antidepressant. This slide is just showing what happens after delivery. The placenta is gone, the allopregnanolone levels drop, the impact on the hypothalamus is less of this allosteric modulation, and it impacts the cortisol axis. So one pharmaceutical company came along and actually achieved FDA approval for Brexanolone, which is this allopregnanolone molecule that they administer. This treatment is very impressive, but it's 60 hours in the hospital. It's an IV administration of the medication. 60 hours is basically spending 2.5, 3 days in the hospital. The cost is somewhere around $35,000. I've not had any patients utilize this treatment yet, but there's a lot of excitement about it. It really is designed for the treatment of postpartum depression, and as a first step, it's a nice start to looking at, can we impact postpartum depression at the very level that defines postpartum depression? Whatever makes postpartum depression different than our garden variety depression, this medication may work in that area. Well, how well does Brexanolone work? In the first 36 hours, percentage of people are saying, hey, I'm a lot better. And at 60 hours, somewhere around half are improved. I'm always surprised that the placebo impact is so high that somewhere around 25% of patients just receiving saline report significant improvement. But the Brexanolone IV treatment for 60 hours showed enough improvement that the FDA said, sure, you can open up your shop and hang out your shingle and provide this treatment to patients with postpartum depression. So I don't have any experience with this, but we may see these types of treatments in the future. There isn't much data on how long this effect lasts. If this turns out to be a long-lasting improvement, it may be worthwhile. If it turns out that this treatment is really only good for a week or two, it's not going to be worth the $35,000 and the 3 days in the hospital. The same company is working on an oral product. This one is not FDA approved. They had the idea that maybe we can use these GABA A receptor allosteric modulators for people with depression, and it was an abysmal failure. There really wasn't any improvement with the allosterone compared to placebo. But they went back and looked at just postpartum depression, and this oral treatment wasn't bad. And the fact that it's an oral treatment and not 3 days in the hospital with IVs was nice to see. I don't have any data on how much this would cost if it ever came to market, but we may see these types of treatment utilized in the few days after delivery for moms. How about alternative medicines? These are commonly used and they aren't well regulated. Well, they're not regulated at all, and so there's always this risk of, who knows what you're getting sometimes. But they're used by a good percentage of families and patients. They don't always tell us that they're using them. Even when we ask, there's sometimes a hesitancy to inform the doctor, oh, I'm using this product or that product that I obtained. Some of the treatments that are probably very effective for depression, though there isn't a lot of data. Exercise and yoga seems to be good for everything. Social and peer support is fantastic. A lot of countries provide support in the home. You hear stories about delivery in Europe where they provide someone to come in and do your laundry a couple hours a week, or someone else to run errands and go to the grocery store. That's not a part of our medical model here, but I often talk to families about getting the extended family involved. The rest of the family often approaches saying, hey, is there anything I can do? And I give them a specific list. I say, sure, you need to help out, watch the other kids, watch the infant. Sometimes if you can watch the infant overnight and let mom sleep for 6-8 hours, that can be really helpful. If you could run errands, go to the grocery store, even mowing the yard can make a big difference for a family that's overwhelmed with a new infant. Therapies tend to work quite well for postpartum depression, including couples therapy, family therapy. Does omega-3 fatty acids help? I don't know, but probably doesn't hurt. Probably good for the heart. St. John's wort, I recommend some caution just because it can interact with other medications. Acupuncture, bright lights, massage therapy, probably helpful. Transcranial magnetic stimulation, this is the MRI-like magnet that it's not as powerful as an MRI, but it directs a little magnetic field at certain parts of the brain, showing some benefit in major depression. Probably not harmful. We'll see if it helps with postpartum depression over time. Another slide just emphasizing that mild depression responds quite well to psychotherapy. And interestingly, the psychotherapy doesn't have to be that sophisticated. Even phone calls to the mom for a few weeks afterwards has been shown to be very effective. We spend a lot of time trying to provide education, handouts, books to read, videos to watch prior to delivery, and that doesn't show as much efficacy as the staff person calling up the newborn mother and saying, "Hey, how are you? Can I answer some questions? What's going on?" Very effective for decreasing postpartum depression. What about specific antidepressants and breastfeeding? Every so often I go through this chart trying to sort out, is this particular antidepressant safe or not? And it's complex, and you're welcome to borrow this slide if you like to review. But in general, antidepressants are probably okay in breast milk, though we don't have large studies one way or the other. There are some studies about how much antidepressant does the baby actually get, and some families will say, "Hey, I want an antidepressant that has the least likelihood of getting into the breast milk." So we usually recommend sertraline or bupropion, which is the trade name as Wellbutrin, and stay clear of fluoxetine. Fluoxetine or Prozac is a very long-lasting product and tends to transfer into breast milk a little bit more than the others. Occasionally you hear about the pump and dump strategy. So families that are really concerned about, does this medication get into the breast milk, and we don't want our infant being exposed to this, what can we do? You can pump for a few hours after taking the medicine, and theoretically you should have a lower concentration of the antidepressant if you use breast milk that's several hours past the administration of the antidepressant. All right, we're going to wrap up with postpartum psychosis. Relatively uncommon, but we have several thousand births a year in Louisville, and we see a handful of patients develop postpartum psychosis. And kind of the take-home message is postpartum psychosis is unfortunately related to bipolar disorder, and many of the patients that present with postpartum depression later on have a diagnosis of bipolar disorder. Postpartum psychosis tends to occur relatively quickly, within a week or two of delivery. Risk factors include a prior psychotic episode and stopping psychiatric medication. Bipolar disorder often presents with postpartum psychosis and tends to be a little bit different than our patients with bipolar disorder not associated with pregnancy. What's different about it? The psychosis tends to be very depressed and situational, mood-related. The delusions and the psychotic thinking tends to be centered around the baby. We see less of the bizarre type of symptoms that we see in our patients with schizophrenia or bipolar illness that presents at other times. We also see a little bit higher rates of delirium. Our bipolar patients and schizophrenic patients are usually not delirious, but in postpartum psychosis, delirium is more common. What's the differential when someone presents with postpartum psychosis? I think of it as bipolar disorder until proven otherwise. And occasionally we see just good old-fashioned serious depression that was so serious that the mom developed psychotic symptoms. Very rarely there's an encephalopathy or delirium picture. Occasionally OCD can present as if someone is psychotic, but usually it's bipolar illness. And I caution families that I need to keep seeing this family member for the next months to years to evaluate for the possibility of a more serious mood problem. What about medications for bipolar patients? Unfortunately, so many of our bipolar medications are very toxic. Lithium and valproic acid have all kinds of teratogenic effects. Antipsychotics are probably safer, but it's no picnic to take antipsychotic medication at any time, so it's particularly challenging in the postpartum period. One of the leading causes of maternal death in the first year after giving birth is suicide, and suicide is actually a leading cause of death in general. As medicine and healthcare has improved in a lot of areas, suicide has crept up the list as the cause of death, especially in younger patients. Postpartum psychosis tends to have a higher rate of suicide than just postpartum depression. Occasionally, we see homicidal thoughts and behaviors. Very, very rare. When it does happen, when a new mom kills her infant, it's just incredibly tragic, and we often hear about it in the popular press, but very, very rare. I've never seen it in my practice and hope I never do. I do see moms that describe thoughts of wanting to harm their infant, and it's different than, you know, the newborn parent that says, oh, you know, I really miss going to the movies, or I can't see my friends right now. I miss my job and my social life, and boy, this kid's a pain in the neck. These moms will say something to the effect that I want to end my child's life. I'm having images of doing something really terrible to my baby. It's very distressing. So a really intense emotion that can occur with depression and psychotic thoughts. What's the treatment for significant postpartum psychosis? I recommend we treat them in a hospital setting. There's so much lability during this period, and that's a significant recommendation in the context of a mom with a newborn baby to say, hey, I need to have you come in the hospital for a week or two at the time when you're supposed to be home spending quality time with your infant. When we do get them in the hospital, we often use benzodiazepines. They work really well in the postpartum period and relatively safe. They're well tolerated. Very rarely you see mentioned in the literature ECT. Thankfully, the medications usually work quite well. Wrapping up, I wanted to mention this graphic novel that came out this year. I heard the interview on NPR and went out and bought the book. It's a fantastic graphic novel, and a lot of my younger patients grew up with YouTube and TikTok and aren't interested in reading a memoir about postpartum depression. But this is a graphic novel with just a fantastic story of an artist that experiences postpartum depression, and she goes through this kind of gut-wrenching thought process of, you know, how can I be depressed in the context of this is supposed to be the happiest moment of my life. I'm a new mom, and I need to be in good shape. But the story is heartwarming, and I've recommended it several times, and many of my younger patients really like this novel. So in summary, mood problems are common throughout pregnancy and after pregnancy. Healthy eating and exercise is good for everything. Therapy for mild cases of depression and medication for severe cases. Alternative treatments are commonly utilized and probably helpful. There's risk and benefits for psychiatric medications, but there's also risk for not treating a mom that has depression. Psychosis is very uncommon, but when it happens, it's very worrisome for bipolar illness. And that wraps up the slide section. So I'm available for questions or comments or thoughts.